navigating healthcare can be complex, as it often involves a multi-tiered system designed to provide varying degrees of medical attention. Understanding healthcare, navigating the levels of care. Tonight, On Call with the Prairie Doc. Good evening and welcome to On Call with the Prairie Doc. I'm Ginger Thomson, your volunteer Prairie Doc guest host for this evening's program. Tonight we're in Rapid City discussing levels of care and answering questions throughout the show. Healthcare services are often organized into different levels of care, which help to classify the complexity of services provided, the resources required, and the specific needs of patients. From your primary care physician to the transplant surgeon, each level of care plays a critical role in the healthcare system, and effective coordination among these levels is essential for providing comprehensive patient care. Joining us this evening are Dr. Tracey Tracy from Monument Health Rapid City and Dr. Brook Eide from Rapid City Emergency Services. Thank you for being with us tonight. Dr. Tracy, could you tell us a little bit about your background and what brought you into this field?
Sure. So I'm trained in family medicine. I've been practicing for 15 years. I did primary care for 13 of those years, and currently now I split my time between the urgent care and between a same-day clinic inside a primary care office, but I no longer carry a panel, but still seeing patients as appointments. And like everyone, I loved the science of medicine. I liked working with people, and fast forward, time goes by, and here it is. I'm 15 years into my career.
Where are you from originally, and where did you get your training?
Yeah, I'm from Oregon originally. My husband and I moved out here 2 years ago, so we're transplants. And I did my training actually in Portland, Oregon at Oregon Health Sciences University there.
Okay. Great, thank you very much. Dr. Eide, tell us a little bit about your journey.
Sure. I grew up on a ranch about an hour north of here, and I'm a South Dakotan. My great-grandfather homesteaded there, so I've been here a long time. Went to college here, and then medical school, and then I trained in emergency medicine in Akron, Ohio, and went into the specialty of emergency medicine, and I've been here in Rapid City about 18 years now, I guess.
Oh, okay.
Time does fly by.
It does. Wow. Well, let's get to tonight's discussion about levels of care. Let's talk about the basics. What are the major specialties in medicine, and what do they typically treat? Dr. Tracy, primary care,
sure,
secondary care, tertiary.
So we're all specialists, right? We all do some sort of extra training after medical school, 3 years to 7+ years, depending on what specialty you choose. And so primary care generally is a combination of family medicine physicians, internal medicine physicians, pediatricians, OBGYNs do a lot of primary care as well. Unfortunately, in the ER, they end up doing some primary care, even though that's not where it should be done. But we all end up sort of with our fingers in the pot, so to speak.
So family practice is primary care.
Sure.
That's what this synonymous.
Yeah.
So I think family medicine is kind of the main thing we think of as primary medicine, because they really do that. But internal medicine does that a lot. Some of them will specialize further, but the core internal medicine, pediatrics, is kind of exactly what you said. And then we have our secondary care, and that's kind of more what we think of as our specialists, even though to Dr. Tracy's point, everyone in medicine does a specialty training, but that's more of our cardiologists and our oncologists and some of those kind of people that get more referrals to them. And then tertiary care is usually thought of more delivered in the hospital. And so that's kind of a much higher level of care, usually a specialist doing something that's not done at all places. Tertiary care is usually performed at bigger places. And then some people even say there's a quaternary care, and that's like experimental, like a beyond tertiary care. Then the fourth level is kind of like specialists that do maybe experimental treatments for cancer and some of those things. They're only done very regional, geographically. And that's kind of a more controversial. But usually there's these three levels of care that people think of as the primary care, and then that secondary care, which could be outpatient, and then finally that tertiary care, which is at a tertiary care center, such as one of our bigger healthcare centers.
Okay, all right. Well, you mentioned internal medicine. So what's that specialty versus a primary care physician? I mean,
Yeah.
isn't there a little bit of
Yeah.
confusion
The
sometimes?
distinction is more an internal medicine physician versus a family medicine physician. So family medicine is trained in taking care of what we call cradle to grave medicine. So we train in obstetrics, delivering babies, we take care of kids, we take care of adults. Internal medicine physicians generally start at age 18 and go from there, whereas pediatricians generally sort of transition patients out when they turn 18. But internists can be specialists as well as primary care physicians.
Yeah, I think that's a good description. So family medicine really takes care of all levels from 0 to 100, all ages, all of those things. Whereas internal medicine is maybe a little more specialized where they just do adults. And pediatricians are maybe a little more specialized where they just do kids, but they're mostly delivering primary care to those populations. And then within those, you can do what we call subspecialties. So if you're a pediatrician, you may become a pediatric oncologist or a pediatric cardiologist. And the same for internal medicine. They can go on to be a gastrointestinal doctor or a cardiologist. But at the core, they're very primary care.
Okay. Where does palliative and hospice care come into this?
Yeah, that's kind of an emerging.
Yeah, it's kind of a newer field. I
Yeah.
think some of them do have specialized training in those fields, and some of them are just internal medicine doctors a lot of times that have been doing geriatric care, doing that care for a long time, and have just kind of made that their niche. So it's kind of right now it's kind of a in limbo type of a thing that's becoming more important as our society starts to value that care more and realize that you can make a big difference at the end of life. You know, sometimes we focus so much on care to that point, not realizing that most people get a vast majority of their health care the last 6 months to a year of their life, and so it's an important time for patients.
Mm-hmm. Why is it important to have a primary care physician?
Super important. I'll let you answer that.
Yeah. You know, it helps to have someone that you can go to, that you can get to know, that can get to know you and your health issues. Someone that can help you navigate a lot of the preventative care measures and screenings that we recommend, as well as somebody that you can go to when you have a new problem or a chronic problem. You know, it's a great home base, so to speak, for your health.
It's kind of a relationship thing, right? Mm-hmm. And so with a lot of patients, it has to be trust, you know, and in this time and day and age, there's lack of trust in healthcare in many ways, but that primary care provider that sees that patient through their wellness stuff and through their illness, and they gain this rapport and trust, and that really helps the primary care provider direct them the right place to go and have that trust in it.
So if I had a health issue come up, is the first place I really should start my primary care physician?
Well, that's kind of a complicated thing as well.
I would say it's never hurts to start with your primary care provider. If we don't know the answer or we think you need to see somebody who knows more than we do, then we will make that recommendation. But there are a lot of things that primary care can do and certainly can start an evaluation.
I think that's the confusing thing for patients.
Yeah.
If you have a new problem, but if I'm having chest pain today, it's probably not best to wait to see my primary doctor, right? And so that's where patients have a hard time knowing the urgency of their symptom. So they have a symptom, and many things can see their primary doctor who can say, yeah, I know what to do with this, and I can handle this, or boy, that's interesting, I'm going to send you on to somebody else who specializes in that area. And that's like I said, that's the confusing thing, is someone is saying, well, is this really an emergency, this ache I have, or is this something that I can make an appointment and be seen?
So I should try to rely on my primary care provider rather than going to an urgent care center, if it's not urgent,
Yeah.
But how do you know?
I think the hard things, and the primary care doctors are really good at knowing. So if you call in there, and if I called tomorrow and said, hey, whenever I walk up the stairs, I'm having chest pain and I'm short of breath, I'm going to make an appointment, they're going to say, no, you need to go to an urgent or ER care, right? And so they kind of can direct that at all times. So it's always a good place to start, I think. Yep. And sometimes it may not be the answer, but it's a good place to start because they can give that direction. And that's kind of the hard thing for emergency medicine, is we're kind of this weird specialty where we're not really primary care, we're not really tertiary care or secondary care. We're kind of our own weird thing, right? And that we do a lot of primary care, like Dr. Tracy said, that unfortunately a lot of people either don't have a primary care doctor because they're healthy, I don't need one, and then all of a sudden they have a problem, or they, for whatever reason, don't have the proper access to them or those kind of things. And so they end up coming to the emergency department for primary care, But we're also kind of a center where if you call the primary care and they say, boy, that's a bad symptom, then they'll kind of direct them to us, and then we can kind of try to figure out how to get them to the right person too, kind of like a primary care would. The hard thing is that a lot of times there's follow-up. If I'm sending someone to a cardiologist, they're going to want to say, hey, it's not the heart, recommend something else, and send that back. But I'm not the one to coordinate that because I'm not their primary care doctor. Where Dr. Tracy would be like, okay, not the heart, now we're going to send it to GI and see if it's your esophagus causing it. And she's going to kind of coordinate all that, or the emergency department is really just kind of a, we see you one time and hopefully you're healthy, we never see you again, you know?
Sure. So, it seems like after, you get to a certain age and, your parents, send you the pediatrician or the family medicine specialist, and then you become adults and you just kind of, unless you need something, you don't necessarily establish yourself with a primary care provider, do you? I mean, why is it important for somebody to do that? And how often should they have a physical? And, I know it depends is probably the answer, but, what would you recommend?
I always think everybody should have a primary care provider. But that's mostly because I see what happens when I see folks who haven't seen somebody for a decade. And we have a lot of catching up to do. Or health issues have gotten a lot worse. And because they've been left untreated, now, it takes more intervention, more medication, more testing, more treatment to try to fix
That's what people
what's
forget,
happening.
the preventative care part of primary care. And so that's why it's important to get a primary care doctor even when you're feeling good, because a lot of times there's things you feel good, but your cholesterol is high or your blood pressure is high, and you don't really feel it, you don't really know it. And so I agree that it's important to have that primary care doctor just to check in, and maybe it might not be every year if you're 22 years old, but just to kind of have that person. And then when you do have a problem, you have someone to kind of help plug you into the system. And so it's really important, especially in that sense, is that they're the coordinators, but they're also the preventative specialists.
In a perfect world, how often should I see my primary care provider?
I think it definitely is a little age dependent. When we're talking about some of the cancer screenings that we recommend, some of them are every 3 to 5 years. Now, I think most of your primary care providers would love it for you to check in annually, and if things are great, fantastic, good, get your flu shot, go on your way, we'll see you next year, sort of thing. But again, sometimes we catch things that you don't feel or see.
So should women, for example, when they get to the age where they need to see an OBGYN, should they go straight to that kind of person or go to their primary care physician and see who they recommend, or do they go both, or what?
Some of that's personal preference. There's a lot of primary care physicians who will be able to do your cervical cancer screening, order your mammograms, talk to you about GYN health, talk about birth control, and OBGYNs do a lot of that as well, and yet they're also surgeons. When there are more complicated issues, then they are the ones that you need. But some people choose to do their preventive care with their OBGYN, and that's perfectly okay.
I'd agree with that. I think that every physician's a human at the beginning of it, so they're going to have their own comfort level, right? And so it may be, hey, I'm not comfortable with this. I've kind of moved away from that in my practice. And so they're going to refer somebody on. Or they may say, hey, I do this all the time, and this is something that if I send everyone to the OBGYN, then they're not going to be able to see the pregnant women that are the high-risk pregnant women that need them because they're so bogged down. And so part of the role, I think, of primary care and the weird niche we serve in emergency care is kind of taking some of that and saying, okay, sorting through it and saying, you need to see someone with a secondary care, a higher level care, and you're someone that, hey, I can manage this here and not keep their clinic. So when you do need them, you're waiting 6 weeks to get in. So if we can kind of keep that from happening, then when you do need to refer them on, we can get them in quickly. So it's we all kind of work as a team. It's all kind of a symbiotic thing, and it's not really a competition. I don't think that family medicine and OBGYN compete over patients because really neither one of them can handle them all, right? And so it's a matter of saying, let's get the right people to the right doctor, and that's the best thing for healthcare.
Speaking of the right doctor, what if you don't know if that doctor is really the right fit for you? Maybe, do you ever feel that with patients? I mean, because it's got to go both ways, I assume.
Absolutely, and I think it's harder if you're a primary care. I don't want to speak for you, but I think that's definitely that relationship that I was speaking of. And so I think you have to have something that you can build a relationship on to get that trust and help with their care, direct them to preventative care and to the right people. Obviously, in the emergency department, that's one of the hard things we deal with is we don't have those relationships. And so when I see someone with their problem, they don't know, hey, is this a great doctor or is this a mediocre doctor? You know, they don't know we have a relationship. And so when I tell them, this is what I think you need, sometimes they're like, is that really what I need? Where hopefully with Dr. Tracy, when she says that, they're like, hey, she's never steered me wrong before, and I trust her, and I've seen her care for my other family members, and so that's why it's really important, and that's kind of the hard place for in emergency medicine sometimes is we don't have those relationships, and so it makes delivering care, giving bad news, giving good news a little more difficult.
What if I didn't think that my concerns were being taken seriously by my doctor? What should I do?
Have a conversation.
Really,
Have a conversation.
just say it.
Yeah, we're all human, you know, and I think the other reality is coming prepared to your office visit really helps. You know,
Let's talk about that because
Yeah.
I like to do research and I know that the internet can be a blessing, it can be a curse. So I'm sure people have said, oh, I looked up my symptoms and
Oh, yeah, all
you
the
know
time.
all this kind of stuff, and or you know they'd print out things, and do you like it when they come in with potential answers to their problems, or I mean, how prepared? What would be the best way to be prepared?
well, I mean, people look things up. That's the reality that we live in. You know, everybody Googles something, you know, and we do spend a fair amount of time going, well, you know, it's probably not cancer, you know, right? Because inevitably, whatever you Google says worst case scenario, right? But then we get to say, okay, right, but that's what's going on in the back of your head. That's what you're worried about. Okay, but now let's circle back around and let's talk a little bit more in detail. And then let's try to figure it out. You know, we're problem solvers, okay? We ask questions for a living. We think about and try to solve problems all day long. But it helps when patients come in, especially if it's the first visit. And you know, for the ER, every visit is the first visit, really. And so if you show up on time, know what medicines that you take, have a list, know what your health issues are. Why do you take these things? When did you last have your colonoscopy? You know, what sort of surgeries have you had? When you know about those things and you can let us know, then you're giving us more information so that we can take that and try to help you with whatever issues happening today.
I agree. It's one of those things that I learned in the long time I've been doing emergency medicine. Is one of the most important questions I ask is, what are you worried about? Because sometimes you tell me your symptoms and I'm thinking of different things that could be and want to work towards that. But if I don't ask you what you're worried about, I'm not communicating well, and in the end, we're not getting there. So if you have these symptoms of your finger hurts, and I say, what are you worried about? And you say, cancer, because my Aunt Sally's finger hurt, and later on they found her to have cancer. Boy, I'm not thinking that when your finger hurts. And so now I can talk about it and say, this is why I don't think it's cancer. This is what I am worried about. And we'll see some things that may tell us that there's cancer or not in the test we're going to do. But so it's really important. And communication is amazing how, as much as that the world thrives on that and we have so much all around us, we really do a poor job of it. In general, I think all of us, and I see that in so many facets from dealing with patients to dealing with other providers to dealing with all these things, is that we really communicate poorly. And I think that the first step is to recognize that and then think, how do I communicate better? And that's really important for our patients, is that we understand what their concerns are. And you're right, the Google thing can be a frustration. But there's actually been times where someone has said, I'm worried about this, and I'll be like, I don't think so, but we'll check that. And sure enough, that is it.
Absolutely.
And so it happens sometimes. But for the most part, it's usually not the case, like Dr. Tracy said, but it's really important to understand that. And so we can address people's concerns, because especially in the emergency department, we always say the three things that we treat are pain, fear, and bleeding, right? And so we can treat the pain, we can treat the bleeding, but the fear, if you don't understand what the fear is of, you can't treat it.
Excellent point. Well, Prairie Doc programming has been a leading source of health education for over 23 seasons. Listen in as Board President Joni Holm discusses the history of Prairie Doc programming and why it's important to continue our mission today.
Hi, my name is Joni Holm, and I'm the president of the Board of Directors for Healing Words Foundation. Rick had a passion for health education, and while he was practicing, he also wanted to do education. He started with a simple radio show that was a half-hour call-in show, and from that, it just developed. He had a television show starting with some pilot shows that didn't take off right away, but over time, he kept trying, and a half-hour show developed into an hour-long live television show every Thursday night, what you know is On Call with Prairie Doc. I know many of you are viewers and enjoy the show and have gained a lot of education through this show. While he was producing the show and practicing medicine, he was able to write 2 books. He wrote The Picture of Health, A View from the Prairie with Dr. Judith Peterson, and he also wrote Life's Final Season, A Guide for Aging and Dying with Grace. With each television show, an essay was written to encapsulate the show. The radio show continues along with podcasts, the Prairie Doc Perspectives, the newspaper articles, as well as the Hopeful Spirit Chorale, which is a choir that was developed by Rick to give comfort to people in hospice. Unfortunately, in 2017, Rick developed pancreatic cancer. Despite his diagnosis and radiation, chemotherapy, and surgery, he continued all of his efforts in health education. In the spring of 2020, Rick demonstrated to his family and to the world how to die with grace. 4 Prairie Docs have stepped up to take the role as host on Call with the Prairie Doc. Dr. Andrew Ellsworth, Dr. Kelly Evans-Hullinger, Dr. Jill Cruz, and Dr. Deb Johnston. We thank them so much for continuing Rick's legacy. They recruit medical professionals throughout the state and the country to help them to educate the public. Throughout the extensive history of On Call with the Prairie Doc and the Prairie Doc programming, we have worked hard to maintain the goal to enhance health and diminish suffering by communicating useful information based on the honest science and provided in a respectful and compassionate manner.
So why is access to health education, like programs like this, important for people's overall health?
The more you know, the better it is, you know. But the more informed you are about your own health, about your family's health, you know.
Knowledge is power.
Yeah, absolutely.
Yeah,
You know.
I think a lot of people don't. I think we assume people understand healthcare and how it works, and a lot of people just don't. And healthcare is kind of its own bureaucracy of the different levels of it and how you're supposed to navigate through those. And we kind of forget that people don't know that, the general layperson. So I think programs like this are helpful to reach out to people and say, hey, this is kind of how things work in the healthcare, and this is the proper way to navigate your way through it. This is what, when you go in, I mean, I've always said, you know, it'd be nice to have a public service announcement to say, when you come in, this is what we want. Most people don't know that. They don't know that when they come in, you know, what we want to hear from them, what details about their problem they're having. There's a lot of stuff out there that says ask questions. And I see a lot of patients at the end of a visit trying to think of a question. I'm like, well, ask a question if you have a question, but you don't have to come up with a question, you know? And sometimes if you're not concise in the way you tell your problem, you know, your provider, your healthcare provider is a person too, and they're going to kind of lose a little bit of focus. And so it's important for people to understand, you know, what we're going through in doing these things. So I think all this is important, and shows like this really help with that.
Okay. So having a primary care provider is the best place to start in most cases.
Okay.
So when do you see a specialist? Do I need a referral? What if I see on a sign that says no referral needed, I can go in and see this specialist? Should I just go do that?
Well, that goes back to your,
Yeah,
it's all different, right?
It is all different, and it's sort of health condition dependent. There are definitely, you know, if I fall and I have a wrist fracture and it's clearly displaced, and it's going to need surgery to reset it or something more than Tylenol to sort of manage the pain, should not be coming to my primary care doctor, should not be going to the urgent care, should be going straight to our, you know, emergency medicine department to get access to those things. But you know, we live in a world of health insurance as well, and some health insurances mandate a referral, some don't. But if there's ever a question of should I see this person for my concern, I'll still always plug, ask your primary. They'll tell you. They'll give you an honest opinion. Yeah, come see me. Nope, we'll send you over here. No problem.
I agree.
Yeah.
Most of the time we can sort through that over the phone, or our nurses in our offices can. So a lot of times we can say, like, you know, that just sounds like something that should go here. Obviously, Dr. Tracy and I could take 30 seconds and look at somebody, I could probably say, you need to go this way and you need to go that way. But not everyone can have that. And that's the nice thing. If you don't know, you can go in, you're going to see Dr. Tracy or one of her colleagues, and they're going to say, yep, I can handle you. Yep, you need to go here. For the general public, it's kind of hard to know. Their wrist hurts and it looks deformed, or maybe it's just a little swelling, and it's kind of hard to assume what people know about their health. And so that's where there are all these places like, we go out to orthopedics, and there's lots of orthopedic urgent cares that you can go right in and see somebody right away. And that can be fine, although sometimes what happens with that is if it's not something that's generally orthopedic, if it's something rheumatologic, sometimes they're kind of focused in on their specialty, and that's the nice thing about seeing someone's primary care, to say, not every bone that hurts is an orthopedic problem. Some of them are other problems.
So if I decided to go straight to an orthopedic clinic, am I going to see the orthopedic surgeon and right away and get in and yeah, how does that work?
Yeah, there's a good chance you're not. I mean, the orthopedic surgeon is a surgeon at fourth and first most, and so they're spend a lot of time in the operating room. So they depend on other people to kind of help them manage who needs to go there and who doesn't. So a lot of times they'll be using their advanced practice providers, their nurse practitioners, and their PAs, and they'll be kind of the first line there for them many times. And so a lot of times if you think you're going to skip seeing Dr. Tracy to see the orthopedic surgeon, that's really not reality. You might see somebody in between. Sometimes you might, but a lot of times you can see somebody in between.
How is all this coordinated between a primary care provider and a specialist? What are there care coordinators, and you talk? How does that? Do things ever fall through the cracks, or is that's because usually if my doctor says, well, I'm going to have so and so follow up with you, I don't know what happens, but magically somebody follows up with me.
The use of electronic medical record has really helped our coordination within healthcare and even within health systems that can now link to each other. Because one computer system doesn't necessarily talk to the other, but as is becoming more and more prevalent, is that many of them do, and we all communicate that way. We share one record. It's not just one handwritten file in your primary's office and one handwritten file in your orthopedist office. It's all together. I can see your orthopedist notes. He or she can see mine. We have ways to secure chat with each other. You can always pick up a phone and call. It still does work that way. But care coordination can be complicated. The more people that are involved, and the more places that you live, and the more health systems that you go to, and that sort of also circles back and does ultimately fall back on the patient, who has to understand their health conditions and be able to advocate for themselves and help us learn, oh, you went to see this physician over in Sioux Falls and I can't see those records yet. Tell me what happened. Give me the story.
I think that's the hard thing about Rapid City, especially in the summer, is that when I see someone in the emergency department, a lot of times the first question I'll ask is, where are you from? And sometimes I'll say, well, I'm from right here, but that's not always our expectation.
Yeah.
We see people from all across the United States and the world that come through our emergency department. Mm-hmm. And that does make it some of a barrier, as when you're trying to figure out, you're having this chest pain, they say, well, I saw a heart doctor. What do they do? I'm not sure. Well, I'd sure like to know what tests have already been done to help with those things. But that's getting better, I think. I think that within our system, for sure, it's really much more accessible to that information. But we're starting to see it accessible across systems, and that's really what's going to change healthcare in the future. When you're summering here and wintering in Arizona, those records will be able to be seen in both places. And so that's going to help us advance the care we give, help probably save money and not doing redundancy in care, and really help give the best care to patients.
So the electronic medical records are now talking to each other better? Wasn't that an issue at first, that there were different platforms and providers?
There's definitely still different platforms. You do see sort of a prevalence of certain brands sort of come out, and when one health system and another health system use the same brand, they can talk to each other.
And what we're seeing that sort through, instead of many different health systems, we're seeing emerge into a few key players. And so that makes it easier because there's more people on the same key players. And so you're right, it's difficult because different health systems and what they're using for their technology, but we're seeing a few emerge. And then if you're kind of in that club with those ones that are emerging, it's much easier to see within those systems.
speaking of technology, in remote areas like South Dakota can be, how does telehealth fit into a visit with your doctor or a visit with a specialist?
Well, I think for primary care, I won't speak for that, but for emergency
I was gonna
care,
say, you guys are probably
yeah, we're starting to see
using
some
more
of it where in these smaller emergency departments where they're just not going to have a emergency physician there, and they may have someone there with just less training, less experience. Now there's access to be able to push a button, have a video monitor, and have someone there with more experience to say, hey, this is what you need to do. This looks this. You're going to do this motion next. And so we're really seeing it take over in those areas. But we're also seeing that, COVID was helpful. One of the few things COVID was helpful for maybe was it did kind of push us along that line of saying we need to be able to get access to people better. And now after that pandemic is done, we're saying, okay, what do we do with this technology we developed at that time? And how do we continue to use it, especially in rural places where if you're 2 hours from someplace, it's really nice to be able to coordinate some of that care. At some point, you're going to need to see that specialist, but at least you knew some of that care that way. I think that's really helpful for the people that live in places like South Dakota.
Sure. So let's talk a little bit about tertiary care, because you said that really is the hospital. So when is that? When do you need obviously, if you need to go to the emergency department or that kind of thing, or is it just in general if you end up having surgery or you can have in tertiary care?
Well, some of it can be surgical, but some of it can be if you're seeing your primary care doctor in a small town and they're going to say, okay, now I'm going to send you to the secondary care, you're going to see a cardiologist because we're worried about the symptom you're having. The cardiologist may say, we do some tests, we say, wow, this is worse than we thought, where you may need a bypass surgery. So now you're kind of evolving your way through the system until you get to the tertiary center, where it has access to more specialists and specialists that are more highly trained in certain areas. And so that's kind of where it comes in.
What does that look like? Can you give an example of that?
Well, I
feel like it comes into your door every day, or I mean, it can start in clinic, it can start in the urgent care, someone who's sick enough that we can't handle it as an outpatient, and maybe they need an additional test that I can't run at the urgent care, and so then we transfer them to the emergency department, where maybe we can get some of those CT scans or contact some of the specialists, and then, oh, you know what, you're sick enough, you need to actually stay overnight in the hospital. So now we're going to ask the hospitalist to be part of your team, who it generally is, it's usually, I would say, an internal medicine physician, but it can also be family medicine physician, but somebody who works just taking care of folks who are admitted to the hospital, and again, helping coordinate all the extra specialists that you may need in a very short time frame.
Yeah, and sometimes we think about tertiary care as being your cancers and your really unusual stuff, but it could be a good example would be like a gallbladder problem. I'm having abdominal pain, I see Dr. Tracy, and she says, I think we need to get some tests and see what it is. The tests are kind of, aren't clear, but the person's having a lot of symptoms, so then she may send him to the emergency department where we do more tests and say, boy, I think this is your gallbladder, we're not sure, we need more advanced testing. So then we bring them in the hospital, get more advanced testing, get a surgeon to see them with their experiences with AC. So that's kind of a classic example, something maybe not so life-threatening, but ends up in a tertiary center because it's just not clear.
Okay, and you talked a little bit about hospitalists, and not everybody is familiar with this term, hospitalist, and how does that work in the system?
It's sort of a newer sort of specialty as well. The reality is that your primary care physician is not traveling to the hospital and taking care of you while you're admitted to the hospital anymore. Those days are gone, and so we have folks who specialize in that, and we call them hospitalists. So they work solely in a hospital, taking care of folks who are admitted.
It's just kind of that more specialized care. As we get further into, we start specializing more and more. And so when I first started in Rapid City, we didn't have hospice. And so I would call Dr. Tracy and say, your patient's here in the ER, and they're having this problem. Dr. Tracy would come in, put them in the hospital. Tomorrow morning, she would check on them before she went to her clinic. And that was really kind of not sustainable. And then during the daytime, there was inefficiencies where Dr. Tracy's busy in clinic and to follow up and order the next test. And so we saw prolonged hospital stays. And so we said, hey, there's got to be a better way to do this. And that's where this hospitalist came in, where they are just in the hospital all the time. And so they can get 2 days worth of stuff done in 1 day. And so it really makes us more efficient in our delivery of care. And it also, although I saw amazing doctors do that, it also lets them kind of hone in and getting good at one thing, and that's saying, hey, I work in the hospital and this is what I do every day. And so they're very good at what they do.
And so when you're released from the hospital, then you're turned back over to the care of your primary care physician?
Yeah, or your coordinating specialist as well,
Okay.
right? So I think our teams in the hospital do a fantastic job of trying to make sure that we have those outpatient follow-up appointments scheduled before folks leave the hospital, so that you have an appointment with your primary or someone in your primary clinic. You know, you've got an appointment with your surgeon or your cardiologist as follow-up when they had recommended that you be seen, so that, you know, we've got those things set for you. So.
And that kind of goes to the importance of needing a primary doctor before you need one, because if I'm in the hospital and I get turned over and they say, we're going to turn you over to your primary provider, who is that? And I say, oh, I don't have one. That's really hard because I need follow-up care. You know, the days of keeping people in the hospital for extended periods of time until we're all better are just kind of over. And so now we're saying, okay, now you can be at home, where in some ways you're healthy, or you're in your own environment, you can sleep better, but you still need this care still. And so that's where we need someone to take over once they leave the hospital. And that's where the primary care provider comes in a lot of times. So that's why it's important to have that doctor. Otherwise, we're getting ready to get to the hospital, and now we've got to figure out who's going to see you next, because those hospital doctors don't leave the hospital.
Sure, sure. Yeah, I can see how that'd be a problem. Okay. Well, have you ever wondered who answers your phone calls when you call in with a question? Part of our health education outreach also involves future health professionals, pre-med and pre-PA students at South Dakota State University. Each week, these students have time to ask questions of our guest doctors and make connections in exchange for answering your questions. Here's more on our Prairie Doc assistants.
The Prairie Doc assistantship is a group of about 12 to 15 students. We get to interview physicians from all over the area, different specialties, for about an hour, asking questions about their specialties, what their day-to-day looks like, just kind of their life balance and everything that kind of involves that. And then while the physician goes on to the live show, a couple assistants go back into the phone studio, and so we get to answer phones from live callers and just pass on those questions to the physician, so then they're able to answer those questions. We're lucky we get kind of a wide variety of physicians, so I know this ranges from like family med docs to all the way to like thoracic surgeons.
We do applications every year for freshman and sophomore pre-med and pre-physician assistant students, and through that application process they fill out an application, answer some questions, and then we also do an interview process, and then we have to narrow down from that group. Once they join, they're able to be in it until they graduate SDSU or decide to move on to something different. It's limited to a few students, but in that way we ensure that we get very high caliber, very motivated students who want to pursue a career in medicine. A huge part of the mission of the group is to kind of upkeep community service and show a devotion to community service, and that's a very important competency to have as a student applying to a professional school. So we have been doing that. In years past, we've done volunteering with the Boys and Girls Club, we've done volunteering with schools down on Flandreau, but currently we're doing volunteering with the South Dakota Children's Museum.
Medical schools, they look at your application kind of holistically and get to see all those experiences you have. So this is something that definitely puts your leg up just a little bit.
Even applying around here in the region during interviews, I've been asked questions by physicians who know about the program and know about the opportunities and stuff, and they were really intrigued about the student involvement with On Call with the Prairie Doc.
I know a bunch of upperclassmen that when I was a freshman, they kind of guided me through the application process and just kind of ways to start looking at how to apply and put yourself a little apart from other people.
We can help each other out with applications or questions on MCATs, like upperclassmen helping underclassmen. So there's just so many different connections that have been made, and I think that those have been the most valuable and most useful to me.
We not only get to see just kind of why physicians went into the field that they went into, but also how they balance their lifestyles and how they're still people and still being great individuals in their community as well.
Well, how important is it to encourage medical students to stay in the state after they get out of medical school? I mean, are we short of doctors in South Dakota?
Everywhere.
I think everywhere.
Everywhere. Really,
Yeah.
always need more doctors.
Yeah, I think it's one of those things. It takes a long time to make a doctor, right? And so anytime you have something that takes a long time to make, there's going to be a shortage. And then we had things like COVID that really made people probably retire sooner than they normally would have, because it was a stressful time for everyone, but especially in healthcare. And so I think that we definitely have a shortage. We have people that don't want to come and live in a rural area like this, because it has challenges to practicing medicine where you don't have the backup of all the specialists, maybe if you're in a small town in South Dakota. So we definitely have lots of need for that here, and it's a challenge for a rural state like ours, but it's a challenge everywhere, I agree.
Sure. So we were talking a little bit before the break about tertiary care is, so you're at the hospital or in the emergency department, and let's say you get released and they say, well, now you need to follow up with your primary care provider. What if you don't have one?
Sure.
Then I understand there's an option out there.
Dr.
Right.
Tracy.
That's Dr.
Actually,
Tracy.
what I do. Yeah.
Wonderful option.
Is that available in most larger cities?
I would say there perhaps is some aspect of that available, but what we actually started here when I joined Monument was we knew that there was an access issue, and by access we mean it takes weeks to months to get an appointment with someone, and we know that there's a need, especially transitioning out of the hospital, to be seen earlier than that. And we sort of developed this bridge clinic. We call it primary care now, but it's same-day clinic appointments that are open to anybody. If you have an issue and you don't have a primary care provider and you cannot wait months to be seen, then that's what we see, and that's where my colleagues fantastically filter to me, and we eventually get folks established with a primary care provider, but we sort of do the right thing for the patient, take care of the patient right now as needed, and you're not just left to sort of wonder, what do I do?
It's not a black and white world, and so even in the emergency department, sometimes we're, in the hospital, go home. Unfortunately, there's these gray areas that are in between. That's like, well, maybe you need to be in the hospital, maybe you can go home. And so when we have an option like Dr. Tracy to say, hey, I think you can go home, we're going to start an intervention, we're going to see how you're doing, and someone's going to see you tomorrow, and then she's going to say, boy, you're not doing any better, maybe you need to be in the hospital. She'll say, hey, this seems to be working, we're going to get you here, there, we're going to keep following that. And that's really important for people. You talk about the cost of healthcare, cost to individuals, cost to our system, and so it's a really big cost-saving thing, but it's also good for the patient, because no one really wants to be in the hospital, no one wants to get woke up all night to ask if you're okay, no one wants any of those things. And so it's good for patients, it's good for our system, and so it's really a great thing that we started here, that I know that in the emergency department, when they told us about Dr. Tracy and this thing that she was setting up, we were super excited, because it's a really good option for us to say, hey, I'm worried about you, but I don't think you need to be in the hospital, but I got a good outlet here.
Is it very common for people to go straight to the emergency department and bypass their doctors, even if it's really not an emergency?
It is. I think, so one of the things we say in emergency medicine is it's the patient's emergency, right? And so some things that I say, boy, that's not an emergency, it's an emergency to that person. And so that's kind of the education part of this, where I think a lot of the general public doesn't really know what's an emergency, what isn't. And so it's their emergency, and so they think they're having an emergency. And that's okay, we're happy to see them, but it does happen a lot. And sometimes it's just lack of access to care. It's one thing if you've got a primary care doctor established and they can get you in, but if you don't have that,
right.
Then it's really hard, when you have a problem, now to start not waiting a long time to get seen, and so, or calling and saying, we don't have any availability right now, this or that. And so it ends up being kind of the catch-all for people who don't have good access.
Okay. So it's very important, we've established, to have that primary care physician, and let's say you're going to look for one. What are some of the things that you should look for or ask, or if you're seeking a primary care provider?
I'll let you answer that.
I mean, do you look at, do you call and see who's available, and then
That's first,
Yeah.
right?
Yeah.
Right, that's first. There's a nationwide shortage of primary care. Let's start there. So, are you accepting new patients? That's question number one, right? If you're lucky and they say yes, then you can, great. But some of it is just, it's kind of a meet and greet. If the personality between that provider and you works, fantastic. I used to tell patients all the time, my personality is really great for some people, and it's not great for others. And if it's not okay and it's not great for you, let's get you to somebody that you are going to connect with and you're going to feel comfortable with and you're going to be able to trust. And if you need a recommendation, I can give you 12. So it's a partnership.
I agree. That relationship, and that's probably more in primary care than any other specialty. That relationship's important. And so if things aren't right there, then you're not going to say the right things. You're not going to the patient's not going to tell you what they need to tell you, and so you're not going to get to where you want to be, and that's the patient's good health. And so it's really, a lot of it's just, how do I feel about this relationship, and do I feel comfortable in it? And the best place to start is probably a referral from somebody, right? And I don't mean another doctor, I mean a friend, a family member, to say, hey, I saw Dr. Tracy, yeah, she was great, you should see her. And so that's a good place to start. And then next, are you available? And then the third step is really just to see how you feel with it. I mean, what's that gut feeling when you sit down and say, is this someone that I want to see for years and have this relationship where they help guide me through my healthcare journey? Or is this someone that just doesn't feel right? And that's okay, like she said, that's okay, then let's get you somebody else, let's try something different.
so
It's like dating.
Great.
yeah, they should have speed dating with doctors or something. So I, if you are looking for another primary care physician, let's say one in the first place, or maybe you're just not comfortable, with the one you have, and you're like, okay, I think I'm going to switch because I want to see somebody new. Then do you, and they say, well, we have 4 doctors who are taking, or like, well, okay, first of all, you were talking about a referral from a friend. So if, you get a referral, but chances are if they say, oh, he or she is a great doctor, they're probably going to be full. Don't you think? I mean, or do they sometimes patients, I mean, you're able to get in after all, or how does that work?
Unfortunately, there's turnover in patients, right? And so turnover for different reasons. Maybe they move, if there's good turnover, we'll go that direction.
Okay.
But so there's turnover, and so just because, and I'm sure you see with doctors, as a doctor gets older, their patients usually get older with them a lot of times. And so if you take over a new practice and you take over someone who's 75 years old, there's a good chance you're stepping into a practice of a geriatric practice more. And so, but then eventually there's going to be bringing in new people. And so that's why I think a healthy practice probably is a good mixture.
Sure.
Right? And I'm speaking for you and I don't know, but there's turnover. So it's always good to ask because Dr. Tracy might be full today, but she may have an opening next week. And so sometimes that's good to kind of check with.
Right. It never hurts to ask. Exactly.
It never hurts to ask. So if they say, yes, we have 4 health providers who are available, 1 MD and 2 PAs and a nurse practitioner. And so, should you always like, well, I want to go to the MD because they know more than anybody else? Or when is it okay to, just say, this PA is fine?
I think that's also personal preference. I work with some amazing APPs who I would happily go see myself for my health care. And then, we have people at different levels of our career, right? We have newer physicians, newer APPs. We have folks who are sort of, closer to retirement, folks in the middle of our career who have a couple years under our belt. And again, that varies with everyone, and there's no straight answer for that one.
And some of it, I think, is sometimes we have our physician who is going to kind of help determine who sees the non-physician providers, right? And so they're going to say, hey, you're really healthy on this track. Our non-physician provider can manage your preventative care and these things. You've got lots of health problems, patient X, like you're someone that I want to come back to see me a few more times, and then maybe we'll kind of mix it in together. Because really, to your point, there's some really talented, PAs and nurse practitioners out there that practice at a really high level. And so it's hard for the patient to know that, but that's where that trust in them. And then once they start working with them, a lot of times, they don't want to leave either. That they could say, hey, I can see the doctor, but I like my nurse practitioner and we have a relationship. And so that's where those relationships can kind of come in.
So that word relationship just keeps popping up. So you're just
Communication and relationship. Those are the two key
just
words here.
absolutely key. They're very good. When can you expect a multidisciplinary approach among your primary care, secondary care, tertiary care, as a team to if you have healthcare issues?
I think that's directed by primary care a lot.
Yeah.
To say, the chest pain, I'm going to start with cardiology and then GI and the different things that can cause pain in this area. And so they're going to kind of be the leader of that multidisciplinary team on the outpatient side. On the inpatient side, it's kind of a similar thing where it's going to be that hospitalist who's going to get different specialists involved and kind of help coordinate that. And so I think that at all levels we have multidisciplinary teams. It's just a matter of who's directing them and who's the general in charge per se, and then and who's putting that all together, because it's really important. That's where primary care comes in. It's really important for that.
I think you'll also see big examples of that with certain health conditions. So let's take cancer, for example, right? There's a lot of different players involved in treating somebody's, breast cancer or colon cancer. There's your surgeon, there's the radiation oncologist, there's your medical oncologist, there's, the nurses that are, on the floor taking care of you. There's the nutritionist, the wound care. Yeah. So some of those multidisciplinary teams are seen more frequently with certain health conditions, or I think.
Yeah, I agree. How complex things are.
Right.
It really comes down to complexity. And so at a basic level, you don't need a multidisciplinary team. You need Dr. Tracy and your primary doctor. As things get more complex, that multidisciplinary team gets bigger, and its breadth and who it involves. And that's just kind of the evolution of how we work our way through the healthcare. And so it's one of those things where we say multidisciplinary team and everyone thinks that's the magic bullet, but really it's not. Really, hopefully I don't need that. I just need my primary doctor. And I count on the wisdom of my primary doctor to know when to make it a multidisciplinary team.
Okay. So bottom line here, you need to have a good establish yourself with a primary care provider, have a good find somebody that you can have a good relationship with, and that you can communicate well with. Is that a good way to sum it up?
That's a good summary.
Okay, excellent. So we'll be right back after this.
My name is Dr. Tom Dean, and I serve on the Healing Words Foundation Board, the nonprofit organization that runs Prairie Doc programming. Our mission is to enhance health and diminish suffering by communicating useful, science-based information respectfully and compassionately. Your donation supporting Prairie Doc programming makes an extraordinary difference. Gifts of any size enhance its impact in our state and beyond. Thank you for your generosity.
Overwhelmed with the amount of information available? Not sure which sites to trust? Head to the Prairie Doc YouTube channel today to access all previous On Call with the Prairie Doc episodes. And make sure to join us most Thursdays on SDPB or streaming on our Prairie Doc Facebook page. As we wrap up tonight's discussion, I want to thank Dr. Tracey Tracy and Dr. Brook Eide for sharing their valuable insights with us. Thank you so much. And thank you to all of our viewers for tuning in tonight. Your involvement and support are what makes this show truly meaningful. Don't forget to follow us on Facebook, Instagram, YouTube, and TikTok for more information and updates. If you missed sending in a question or it didn't align with our topic, send your questions to ask@prairiedoc.org to be answered on our weekly radio program, Prairie Doc Radio, Sundays at 6 a.m. and 1 p.m. on SDPB Radio. And be sure to download and subscribe to the podcast version of the show and Prairie Doc Radio wherever podcasts can be found. Thank you for joining us for another On Call with the Prairie Doc. Until next time, as our founder, the late Dr. Holm, would say, stay healthy out there, people. Major funding for On Call with the Prairie Doc has been provided by
At Avera, our nationally recognized health system will be right here with you, with care and coverage. Hello possibility. Hello healthy. Hello life. Avera, moving health forward.
Larson Manufacturing is proud to support On Call with the Prairie Doc as it continues to open doors for important medical information. And with the ongoing support of these individuals and institutions: Brookings Health System, South Dakota Academy of Family Physicians, Sanford Health, Avera Medical Group Brookings, Avera Heart Hospital, First Bank and Trust, Dakota Allergy and Asthma, Monument Health,